I really want to talk a little bit about, within our very special patient population, some of the factors that I think are true across the board in bringing nutrition, probiotic, other types of microbial solutions to the market. And hopefully, given my experience in bringing technologies from a lab to the market, we can have a really robust discussion around how we see this field evolving and really being able to bring new solutions to this very critical patient population. So we talked just a little bit, and I really am not here to talk about myself, but I do want to express that my perspective really comes from business and from finance. And it's probably very different than many people in the room, but I think it's an important element when you think about actually bringing these things all the way to market. There are great scientists, there are amazing clinicians, and there are factors around marketing and providing claims and regulatory support. But let's also think about the business side of microbial interventions and how we start to impact the space, bringing all of those features together. So we always start with the problem. I think we've talked a lot today about nutrition very broadly, about how gut health in particular, the intestinal microbiome is affecting different patients throughout life and how nutrition and microbial interventions can do it. We had great panelists talking about intended use and labeling. And I think it's really important as we go through this today to also then talk about parameters. I call them the market and clinical forces. So having a great idea, having an efficacious solution is important, but you also have to understand the environment in which you're operating. And so for us, we're talking about the clinic. We're talking about these tiny babies in the neonatal intensive care unit. And there are some very important factors that we have to think about when we think about microbial or other nutritional interventions for our patient population. And then ultimately, we have to think about the product, not just the technology or the mechanism of action or what we're making, but how that product is actually received and how we get that into the hands of clinicians, consumers, and patients. So my favorite topic, right, is preterm infant gut health, which you may or may not know, about 10% of babies are born preterm here in the U.S. About a third of those are weighed just under 3 pounds, so they're low birth weight. And they have some very unique and distinguished features because this is a period of time where they're in a clinical setting, some of them for very extended periods of time. So as Dr. Vanderhoof talked about, their influences of environment are relatively limited to that space. The nutritional options for these babies are also relatively limited. We provide them mother's milk, donor milk, perhaps formula, but there isn't this cornucopia of foods that are ultimately introduced to infants as they grow. This period of time has a relatively limited menu. And I think probably as importantly are some of the challenges that we see in this patient population that are exacerbated, and I'll talk a little bit about those statistics. So what you may not know, we can survive infants as early as 22 weeks gestation, so just about halfway through a pregnancy. These kids can be born weighing under a pound, and while they survive, we've really struggled to help them thrive. 50% have what's called postnatal growth failure. So these are kids who are born, say, at your 50th percentile for weight, who end up going home at the 10th or even the 3rd. More than 40% of these kids have developmental delays or disabilities. And throughout their life, they are at a greater risk of these immune-mediated conditions, many of which Dr. Vanderhoof talked about earlier. And we know that the gut plays an incredibly important role in this period of time, right? It's driving growth and physical development. It helps develop that brain properly. And as we talked about, it is that largest organ of immunity. But from a clinical perspective, and what we think about with our users and for our patients is you really don't have a way to measure the gut. Apart from doing sequencing and other sort of scientific approaches in the clinic, there isn't a way to know what is happening in the gut of these babies. So I'm a numbers person. I'm going to throw up some statistics for you. As I said, there's almost 400,000 kids. About a quarter of them are low birth weight. Average charges in the hospital, these are just inpatient, are over $250,000. They spend 77 days in the neonatal intensive care unit, some of them spending up to 120 days. And from a societal perspective, annual costs are estimated at $26.2 billion. So while these are little kids, and maybe not a ton of them, they're incredibly complex and expensive and deserve better solutions. So we talked a lot earlier about antibiotic use and how that impacts the gut. Almost all preemies are given AMP and GENT, so antibiotics initially in their first 48 hours. This obviously has a huge impact on that early establishment of the microbiome. They're fed based on age and weight, which is quite ignorant of different microbial risk factors that these kids might have, but it's the best way that clinicians have today to measure when and how to feed. Hospitals have protocols that state when to introduce feeding, so when to start to do enteral or gut priming feeding, how frequently to advance, when to fortify. These clinical practice guidelines exist. But based on symptoms or based on other activities, whether it be a surgery or other kind of interventions happening, there are a lot of fits and starts in feeding. And what's so critical is that that nutrient is helping that body grow and that brain develop. And so these fits and starts are causing or exacerbating a lot of the challenges. Probably also the big challenge, again, a market parameter for us, is that electronic medical records have really impacted documentation requirements and taken nurses and clinicians away from the patients. And yet they don't provide that very important nutritional and feeding data readily available. There aren't a lot of clinical interfaces that kind of give you that nutrition dashboard. And knowing how important it is to the growth and development of these kids, it's really become a challenge. You've still got paper and clipboards and calculators out for dietitians and nurses. And while we'd love to see, I think, opportunities to introduce microbial interventions to perhaps attenuate an inflammatory response in the gut, there's very limited use. And for NICUs that do use probiotics, it's an all or nothing strategy. They're given to kids or they're not given to kids. There's no tailored way that they're delivered, which I think has impacted efficacy and certainly challenged adoption more broadly. And our babies have some unique challenges of their own. They have very low diversity, probably not surprising. It's a relatively controlled environment. And these in many ways are fetal people. And so what you'll see is very high inter-patient variability, which makes it very, very difficult to create a one-size-fits-all type of diagnostic. The rapid change that's happening in their gut, both from a developmental perspective, but also from those impacts of nutrition and antibiotic exposure, make it really ill-suited for sequencing or doing any other kind of profiling in a time period that actually can be acted upon. And I think we talked a little bit about clinicians' comfort with the microbiome. I think there's awareness, but there's certainly a very difficult challenge in translating their understanding that these different microbial health risk factors impact these babies. But what do I do? So if I have a cesarean-born baby and a vaginally born baby, how do I treat them differently? How do I interpret that different microbial factor? And then we've talked a lot today on regulatory challenges. I'm an optimist. I do hope the field continues to move forward. But in this patient population, somebody asked a question about pregnant women. Imagine trying to recruit preemies, especially extremely low birth weight preemies, for a trial. These are parents on their worst day of their lives, worrying about survivability. And so clinical trial recruitment and patient identification in this patient population is extremely difficult. For hospitals and users of many of these systems, these are very tight budget times, and so you're seeing very long approval processes for getting new technologies into the clinic, and whether they be nutrition-based or other types of therapeutics or interventions, that last mile can be extremely costly and long. And then value-based care incentives, we hear a lot about this, right? We're moving to value-based care, but for our preemies, they're usually under a bundled package. And so getting them home sooner and improving their overall health when they leave the hospital really isn't aligned with where the payment system is today. So we've got layers of this onion that we've got to start to peel away. So what do we need, right? We need an ability to quantify the state of the gut, that host response to what's happening in the neonatal intensive care unit. And we need it in a way that's, excuse the pun, but digestible to these clinical teams, right? They're in an intensive care setting. They've got critical patients all around, and they really need information that tells them what is happening and what are the options for me, the clinician, to act upon that. Our belief is that if you can empower these clinical teams with the right information, they can better tailor how they treat these kids based on that gut health. And we believe very strongly you need an evidence-based tool to accelerate the advent of some of these microbial and nutritional interventions. If you knew as a company and as a clinician that this child was having an aberrant gut response, high inflammation, say, as an example, you would be far more confident in using a microbial intervention, knowing that it was targeted to have the best effect. And I was very grateful, Dr. Vanderhoof covered this as well. There's a lot of publications out there around mode of birth, type of nutrition, antibiotic exposure. And again, they're siloed studies. They're interesting studies, very, very informative in their own right, but nothing is ever a single factor. And so how do we think about taking all of that great work and turning it into something that can then come into the clinic? The beauty is we've got great tools. There's a ton of vendors outside with them. We've got shotgun sequencing available. We've got things like machine learning and AI, which can actually really start to take all of this disparate information and start to create actionable insights. But I think it's important for everyone who's interested in our preemies that you understand that clinical workflow is a huge, important hurdle. We can't create additional work in this very intense setting. And so these solutions have to be very straightforward and have to be very efficacious. So I'm going to do just a quick example. I'm a big use case person. 2 kids here, baby Chance, baby Hope. Today, same weight, same gestational age, treated very much the same from a feeding perspective as far as how much volume they're getting, whether or not they're being fortified, etc. But if you can imagine a risk score, let's say, as just a concept here, right? Microbial risk factors being designated to help these kids be stratified, right? Low risk versus high risk. We can go into the science or the theories behind this, but just imagine these are all different factors that are known to influence that early establishment of the microbiome and how it changes over time. What you would then find is with baby Chance, who's high risk, you would use antibiotics, fear of infection or other conditions, right? But you would have a very slow and deliberate plan for feeding that child. You'd be very careful in introducing things into a high risk or high inflammatory gut. And this is a case where you could be very confident in attenuating that inflammation with microbial interventions. But you take a baby like Hope, who has very low risk, perhaps you could start to see a delay or even an elimination of that early antibiotic exposure. Better stewardship of that very intense GI assault early in life. You could be more aggressive in feeding, advance more quickly, provide that nutrient, and help that baby grow and stay on her growth curve. And ultimately, maybe even introduce things like prebiotics here to help stimulate and support that healthier environment. And with this, we obviously hope to achieve growth, improved neurodevelopment, and shorter lengths of stay, getting these kids home to their babies, to their families sooner. I think it's important too, is I'm again coming back to the business side of this, there are certain factors that I think are critical in this space. And again, we're in a very high intense clinical setting, maybe very different than consumer marketing, which I know very little about. But the science here has to be very well vetted. If you're talking about a critical patient population, the science has to be sound, the studies have to be well designed. And I think the important to that is early and often engagement in regulatory. You also need to be talking to the customers and the clinicians who are treating these kids. These factors, new nutritional solutions are provided often, right? There's a very strong push right now for an exclusive human milk diet. Is that right? Well, how does it change microbial intervention? Does it matter? All of these factors create more complexity in this patient population. But I think as we kind of pool the data and pool the learnings, we actually could create some pretty unique opportunities to personalize care for these babies. I think we should partner. I mean, there's a lot of groups doing diagnostics or interventions. The better we partner and bring together solutions, I think the greater impact we can have more quickly. Again, don't ignore economics. We have very expensive babies here, but we can't, it's not a price inelastic market. There are other factors you need to consider. And persevere. Things never go according to plan when you're developing anything. I have no doubt that microbial interventions will see their own fair share of unique challenges. But I do believe in the future of preterm infant nutrition. I do think there will be decision support tools. I think we'll have an ability to measure the state of the gut. And I think really the goal here is more of a precision approach to care and feeding with better information and better solutions to help these kids. And that's my talk. Thank you.
Hi. Enjoyed your talk. You mentioned the antibiotic use. Sounds like within 48 hours with these babies. How long typically do they give these children antibiotics? Like the entire time they're in the NICU? Can you speak to that?
Sure. My understanding, and again, I'm not a clinician, but most are given an early kind of single dose early in the first 72 hours. It varies by institution. It's not a perpetual dose unless the child has other challenges or conditions that the clinical team is worried about. But as with any child, if they're sick, they could be getting courses throughout their length of stay. But practice today is just a single prophylactic treatment early in life, which I think, has been the standard of care. But if you really sit with a neonatologist, it's something they wish they knew whether it was needed and if they could avoid it. But the studies haven't been done.
Or near future, we will see more microbiome technologies and economics that is becoming smaller and more compact, becoming a standard point of care approach where you can bring it to the patient, really play a role, and you can diagnose very quickly skin, saliva, stool. Do you think this will play a role?
Oh, absolutely. I think the question is, do we need to wade into that diagnostic paradigm? And I think what I caution against is that diagnosing the presence or absence of a strain, as an example, may not in and of itself translate necessarily to an actionable for all patients, right? So I think, yes, we do need point of care solutions, and we do need an ability to then act upon them or stratify patients differently. And I think there's good hope there that panels or other sort of quick tests can be on the horizon. I think the question is more, how can we get to more of a personalized, there's so much variability, whether it's adults or our babies. How do we start to think about medicine in that environment with that information? And I think there's a lot of puzzle pieces that are still missing that we all need to fill in.
Hi, thank you very much for that. I think this is really a fascinating field with a lot of potential benefit for clinicians. I am a clinician. I'm not a neonatologist, but I'm a pediatrician. And I think one of the points that I think you're alluding to is if you think about using microbiome technology diagnostically to say, okay, is there a pathogenic bacteria or not? That there's a whole lot of problems with that. It's like people doing whole body MRIs. You'll find out a lot of information, and a lot of things may or may not seem unusual, and it's a real challenge to know what to do with them. And the parallel is, as a clinician, if a child is having diarrhea and you do an open parasite exam, very frequently you'll come up with results saying, this thing is there. And then, but it doesn't answer the question of well, okay, it's there, and the more sensitive your methods are, the more likely you are to find something. But knowing what to do with that is a real challenge.
Yeah, I couldn't agree more. I think one of the interesting conversations that should continue to happen, and that we touched a little bit on this earlier today, it may not be a presence or absence thing that can trigger, right? It's community, it's how they react to one another. We talked about all these things in the different panels. There's just got to be a lot more work, I think, thinking about the factors within the presence and absence, right? So sometimes certain bad actors help maintain the presence of good actors, and so wiping them out isn't always the best thing. So I think we've got to be very agnostic in our approach initially to start to think about changes. Maybe it's how fast the microbiome is changing or how quickly it's becoming more diverse, as opposed to what's joining the community. I just don't think we know all the answers yet, and so we wade in carefully before trying to translate that to the clinic.
Sure. Kind of as an extension to that question, can you give some examples of what you guys are doing right now?
Well, so as it in neonatology or at the company, or
at the company, what are you guys measuring and how are you acting upon it at the moment?
Yeah, so we're developing a tool actually using machine learning, and we're agnostic as to the factors. We're not going in with a hypothesis of healthy versus unhealthy microbiomes, but we are looking at outcomes in our preemies. So we have longitudinal shotgun sequencing and actually metabolomics of our babies. And we're looking at function and presence and absence within the babies. But our goal is to create an algorithm. It's really meant to be a tool that isn't diagnostic, but rather just helps in this early stratification of risk. And I think we've got to, again, from a clinical perspective, risk scores are very easy to understand. Blood pressures, when you're thinking about hypertension, is very easy to understand. And maybe we start to use those to then bring in a new set of solutions. Though that won't be our company, but some of the companies here. And that's really our hope, is if you can standardize measurement, you can start to help to bring in more insights and understanding, and then microbial interventions we hope will follow.